Yeah, thank you. Very interesting talks. Question for Professor Mamode. Has nothing to do with robotics. Just a question. So, as I understand, it's the time of the warming of the kidney that is the problem, and it's because of the patient's body temperature, essentially. Can you not cool the kidney while it's in the patient? Because I saw you had the kidneys like in a bag before you release it. If you had cold water running through thin segments of their bag to keep it cold, wouldn't that help?
Yeah, it's a good question. Yes, you can is the short answer. There was a surgeon in Newcastle who developed something like that a few years ago, about 15 years ago. It never really took off. One of the difficulties is that any kind of bag around the kidney with fluid flowing in and out is going to be a bit bulky and get in the way. But I have heard recently that there is a newer version which has been developed, not from Newcastle but from somewhere else. I haven't seen it yet. So that is a partial solution, perhaps. It's never going to stop the kidney completely from warming up, but if it slows it down, it may help. Some robotic transplant surgeons put ice on top of the kidney and into the abdominal cavity during the procedure. That ends up cooling the patient by about 0.5 degree, which doesn't sound much, but like global warming is very significant.
Thanks.
So another question to Professor Mamode, please. Can you tell me, please, what was the drive behind using robotic surgery in kidney transplant if the price is very expensive in relation to arterial thrombosis, graft rejection, and length of time? And would you think, from your experience, that laparoscopic assisted kidney transplant, where you can use the muscle splitting technique in a small wound in the midline to introduce the kidney, and then do your anastomosis quicker under vision, would be a sensible option?
So to do your anastomosis under direct vision using open instruments with the rest of the procedure performed laparoscopically is difficult. You need to make quite a big incision to do that. It's quite difficult to do. So the drive is really to convert an open operation into a minimally invasive one. And if we look at what happened with living kidney donors, so for living kidney donors, when I started, we would take them out through an open incision, often divide the 12th rib, big muscle cutting incision. In the early 2000s, we started using a laparoscopic approach. And we were able to show that there was quite a significant difference in terms of outcomes, length of stay, pain recovery, and so on. And that's now standard of care. So I think the difference in outcomes is likely to be similar. The question is whether that difference justifies the expense. At the moment, it probably doesn't. But with newer systems coming in, which are cheaper, I think that balance will probably be found. In terms of the complication rates, it's very difficult to say at this stage. So again, if we look at the donor experience, there were a number of donors who actually died through the laparoscopic procedure early on in its adoption, and they were relatively poorly reported. But that happened. I think people realized what they needed to do in order to learn the procedure. It wasn't just a straightforward operation. I think the same applies to robotic transplants. We need to know what we're doing. We need to have adequate training to make it safe. So I think we're learning that now.
There's a question up front here.
Thank you very much to the wonderful speakers. My question is for Mr. Bolger about corneoplasty. Just wondering, what are the long-term consequences or complications that one might expect? I ask this from a personal point of view because, like you said, most of us here are myopic. And if we're going to have the consideration for...
my hearing is not
okay.
good, so I'm really sorry.
Yeah, I'll take it slowly again.
Speak a little louder and more slowly.
Just asking from a interest of personal interest, Like you said earlier, most of us here are myopic. And the corneoplasty, which you described with laser surgery, is probably the way to go going forward. So we can avoid using glasses or contact lenses. So what are the long-term consequences, if any?
Of the SMILE procedure?
Yeah.
The SMILE procedure is aimed at the younger group who still can accommodate. So these, when we correct their focus back onto their retina, give them sort of natural vision, when they want to see different distances, their own lens will auto-accommodate, just like normal. So we don't need to worry about autofocus or multifocality in that age group. It's when they become presbyopic, that's a whole different ball game. And I have no doubt that when your turn comes for presbyopia, there will be a lens that will autofocus. I'm sure that's going to come. The technology is almost there already. The long-term effect, the long-term of this form of laser eye surgery, this is about 14 years in the practice, and it's very stable. It doesn't fluctuate. But obviously we don't have any 24-year results and so on. But it is very safe, and it's very it's got a good database of safety. And what my last slide there was about, people kind of think, oh, I won't get laser because it's dangerous, and then they wear soft contact lenses. In the lifetime of a myope, you're more likely to have catastrophic loss of vision due to a complication from a soft contact lens than to have a laser procedure go wrong and cause catastrophic loss of vision. But people kind of think, oh, I'll wear contacts because it's safer. It's the other way around.
Thank you.
Just one final question in the front, I think.
The technique, this is for Mr. John Bolger. The technique is fascinating, and the way you present it as well. So thank you for the fantastic presentation. But the question is, you're saying that about 14 years data you have. Do you keep your data, and what are the major complications, and whether people are aware of those complications, as I'm sure you have come across?
As I said earlier, the complication rate is extremely low. I mean, being a myope, you're at risk of visual loss. I mean, it's kind of outside the remit of this meeting, but you know there is a pandemic of myopia, and they estimate by 2050, 500 million people will be blind from myopia. That's the population equivalent to the current EU. And when I say blind, I mean unable to do work for which vision is necessary. So being a myope, you're at risk anyway. If you're a myope and you wear soft contact lenses, you're at risk of losing vision from soft contact lens complications. The level of risk here is like the number. I would imagine, off the top of my head, I think it's about, for every 50,000 lasers, we might lose 3 or 4 lines of vision in one eye, which is really a small price to pay overall. Not if you're that patient and so on. So this is very safe. And it's safer than wearing soft contact lenses. And it's literally, we do tens of thousands of these and almost none go wrong because it's robotic. The monkey on the back of laser eye surgery is the old lasers. Now the technology for those was completely different, massive spot size, very dispersed energy going all over the place, a completely different technology, and shouldn't be compared. So the old laser bugs have nothing to do with this technology.
Thank you.
Okay, one more question over there, and then I have a couple of questions.
You mentioned the old laser is bad, but the new. Is that being the regulated?
Can you? I'm gonna have to, because I'm waiting for one of these cochlear implants.
Yeah, well, we can help with that. you mentioned the old laser is the bad cop, the new laser is the good one.
Yeah.
But are the regulators involved here to tune out the old laser technology? Are they being replaced completely, or are you saying that it should be replaced?
I mean, there are still clinics using older technology, but the really old lasers are gone. You know, the ones with the big diameter spots and so on. But there are 3 of these these robot lasers in London, and there's around UK. And more, the ophthalmic community has accepted that this is the way forward. LASIK, where we lift a flap and use an excimer laser to burn away the bed, is still a good procedure, and it's a bit like saying a full incision renal transplant is a perfectly good operation. The patient does well and they survive and they live a good life and so on. But you probably would agree that if you were going to have a transplant, you'd want it done via a robot because of the less morbidity. And I think it's a general principle of surgery that it's the incision that kills or makes the patient sick. That was certainly the case with cataract when we had a 12 millimeter incision. It's now a sub 2 millimeter incision. And the difference in the post-op recovery and the general morbidity is much less. And talking to general surgeons, and it seems to be the case that the smaller the incision, the quicker the patient can recover and the fewer complications you get. So your question about these other lasers, there may be some around, particularly in other countries, in Eastern Europe and so on, but more and more, and nobody would buy one of those. I don't think they're even available now, but they're more and more we move towards this femtosecond technology.
I have a question. I'll ask it to Vinidh and Issaq. So what we're seeing in some of the results here is that the effect size or the functional outcomes are relatively small, if there are any. That could be a consequence of having relatively few procedures when we think in the larger scheme of historical operations. And therefore, one of the barriers there is the uptake to these technologies. My question is, where is the cost in these technologies? Is it in the machinery, the development of the machinery, or is it in the software itself? Is it in the manufacturers developing the software? Where is the larger cost here?
If you look at Da Vinci, as opposed to costs, is they're trying to recoup their development costs and whatever goes on in installing the machine. From an operative perspective, within head and neck, the costs are fairly modest. It costs us an extra £500 per patient for the consumables. With that in mind, the savings, if you look at the savings for, let's say, a recurrent cancer, we do a transmandibular, transcervical approach would inevitably need a free flap reconstruction. So you're talking about a 10-hour surgical procedure, which you could potentially convert into a 2-3 hour procedure by not performing it as an open surgical technique. So there are cost savings from our side for the investment. But then any cost you have to look at from a bigger picture perspective. The 1.6 million you spend on the current market leader is a multi-specialty robot. It's urology being the prime movers for Da Vinci. So if you run it as a multi-specialty initiative, certainly there are cost savings to be made if you look across the board.
So that was my follow-up. My follow-up question was going to be, have you seen a trend, or is there any initiatives where there are open source frameworks for the software which operates these robots? That's what we've seen in terms of AI. The innovations in AI have come due to open source frameworks and development frameworks. Is there something similar in this domain?
So the Russian robot, the picture I showed you, and the Mantra, there's a Indo-Chinese collaboration, both have open source software driving their robotic instrumentation. But clearly they're meant for a different market, and they will then need to come through FDA and CE marking before they get marketed elsewhere. But they are being developed at a relatively rapid pace, is what I understand.
Thank you. Okay, well, I think that's it with the questions. I'm going to wrap up. I run the risk of standing in between you and your champagne, so I'll keep this quick. I hope everyone found this to be a fantastic meeting. I certainly did. Not being a clinician or a surgeon, I found this truly illuminating. And what I would like to see, this is a conference on AI and robotics. We saw a little bit of blending of AI going into robotics, but I think what stands out is there's much more need for collaboration. I think the medical community collaborating particularly with academia, but also some of the leading commercial companies doing AI. I think there's so much talent in AI, and a lot of that talent wants to work in healthcare, so I would encourage greater collaboration. Just one other bit of housekeeping before I wrap up. Our sponsors, Towergates, are announcing a prize draw winner, so that will be at the champagne reception. And you can also find your CPD certificates outside by the specialist info stand. So I won't stand in between the champagne any longer. So thank you, everyone.